Welcome to the Interventional Cardiology Virtual Educational Summit, presented by Johns Hopkins University School of Medicine at CardioCare Live. My name is Roxana Moran, Professor of Medicine at Mount Sinai School of Medicine, and you are tuned in a live session called Assessing Progress in Coronary Stenting with Dr. Greg Stone. Dr. Stone is a professor of medicine at Columbia University and the director of cardiovascular research and education of the Center for Interventional Vascular Therapies at Columbia University Medical Center and the Cardiovascular Research Foundation in New York. Before we get started, I would like to remind you that we will be taking questions in real time throughout this presentation. You can send me your questions anytime during the program through the box in the lower left-hand corner of your screen. Thank you. So we'll get started. Welcome. Hello, Dr. Stone. It's really wonderful to have you, and we're really looking forward to your presentation on assessing progress of coronary stenting.
Well, great. Well, it's great to be here, and thank you. And I've got a lot to try to cover in the next 30 minutes. In fact, I'm going to try to cover practically the history of coronary stenting, where we are, where we came from, where we are, and where we're going. But I'm going to cover it from a point of view of the patient. And that is, where does PCI with coronary stenting fit in the treatment of basically simple, non-complex coronary artery disease, where the main alternative is medical therapy? What about the treatment of complex coronary disease, where the patient needs revascularization, either multivessel disease or left main disease? And how does the current generation of state-of-the-art drug-eluting stent fit in this equation versus where we're going, and that is with next-generation drug-eluting stents? So we can very simply dispose of acute coronary syndromes, that is acute MI and non-ST segment elevation myocardial infarction. With STEMI, we understand the pathophysiology of a ruptured plaque with an occlusive thrombus. And there have been 23 randomized trials of PCI versus the best medical therapy, that is thrombolytic therapy, overall showing about a 2% absolute reduction in mortality, a reduction in reinfarction, and of course about a 50% reduction in stroke and a near elimination of intracranial hemorrhage by avoiding the iatrogenic complications. So I don't have to tell anybody primary angioplasty for STEMI is standard of care in all but the patients who have the greatest delays. When you look at patients with non-ST segment elevation MI, now we're talking about a routine invasive strategy where patients then get triaged to either PCI in most cases or bypass surgery or medical therapy versus a selective invasive strategy of only going to the cath lab for severe recurrent ischemia or spontaneous recurrent ischemia. And if you look at the three large studies that have looked at the overall death rates, cardiovascular death or MI, now 5 years later, you can see overall a significant approximate 20% reduction with a routine invasive strategy where about 70% of the patients actually get PCI. So for acute coronary syndromes, urgently or emergently going to the cath lab and then being triaged and usually towards PCI is standard of care. But when we talk about stable coronary artery disease, we've got a very different kind of clinical syndrome. This is pathologic interval thickening as opposed to a ruptured fibroatheroma. And here you have a syndrome which can lead to angina, ischemia, shortness of breath, exercise limitations. But these are relatively stable lesions, and they rarely rupture, they rarely thrombose, they rarely lead to death or myocardial infarction. And as a result, most studies that have looked at, for these relatively simple types of lesions, for example, COURAGE, which randomized such patients to optimal medical therapy versus PCI plus optimal medical therapy, don't see significant differences in the rates of death or myocardial infarction. And as you can see here, overall, the rates of death and MI are relatively low. Myocardial infarction, usually 1 or 2% a year, and death about 1% a year. Now, there is a benefit of PCI in patients with stable coronary disease in terms of improvement of symptoms. And when you take patients who have 2 or 3 episodes of angina a week, then there's quite a robust reduction in symptomatology with PCI compared to even the best medical therapy as practiced in COURAGE. When you look at patients with silent ischemia, though, that there was actually even a trend at some periods for harm for doing PCI in terms of increasing symptoms. It's hard to make people feel better if they're not having angina or anginal symptoms. And it's also true that in these patients, PCI does lead to less requirement of anti-anginal drugs, less nitrates, less calcium channel blockers, etc. But we haven't been able to show a reduction in death or myocardial infarction with PCI, and so optimal medical therapy may be considered an acceptable first approach. However, in the last several years, there's emerged a very strong relationship between the amount of ischemia, either at baseline or after an intervention, whether it's after PCI, bypass surgery, or medical therapy, in terms of the subsequent rates of both death and myocardial infarction. As seen in the COURAGE nuclear substudy, if you have 0% ischemia, you've basically got 0% death or myocardial infarction going out several years. And as you have more and more ischemia on this quantitative SPECT testing, you can see the death or MI rates even go up to 40% over about a 4.5-year follow-up period with greater than or equal to 10% ischemia. And therefore, if you look at the amount of an intervention in reducing ischemia, you can see interventions that reduce ischemia, whether PCI or medical therapy in the COURAGE nuclear substudy, they are associated with prolonged freedom from death or myocardial infarction. And if you take patients on the right graph with moderate or severe levels of ischemia at baseline, those patients who have a significant reduction in ischemia have really quite a marked reduction in death or myocardial infarction. Now, in this regard, when you look at both medical therapy on the left and PCI on the right, what's fairly striking was that pre versus 6 to 18 months later, medical therapy, actually even the best medical therapy as practiced in COURAGE, doesn't significantly reduce ischemia. And that was fairly striking. An average of 8.6% ischemia baseline and 8.1% 6 or 18 months later. On the other hand, PCI is practiced in COURAGE, and this was mostly bare metal stents, no drug-eluting stents. Actually, a mix of balloon angioplasty and bare metal stents was associated with a fairly striking reduction in ischemia, p-value of less than 0.0001. So optimal medical therapy, statins, etc., are certainly beneficial and have made major inroads into improving the prognosis of patients, but I believe it's mostly by stabilizing the unstable atherosclerotic plaque, leading to less fibroatheroma development and rupture. In contrast, if you want to relieve ischemia, you need revascularization, whether PCI or bypass surgery. Now, there have been 3 smallish randomized trials of just ischemia looking at PCI versus medical therapy. This was the ASIP pilot in 1997, the silent ischemia subset of the COURAGE trial, which Bill Bowden presented, and the SWISSY 2 trial. So these patients all had ischemia, and in all 3 patients, there was actually a reduction in mortality with PCI compared to medical therapy, a fairly striking reduction, almost 2/3. But none of these should be considered pivotal randomized trials that were powered to show a 2/3 reduction in mortality. Now, we do get some more insights from the most recent contemporaries trial, and that's the FAME-2 study. Unlike COURAGE, this is a study that did use best-in-class drug-eluting stents. And it took 888 patients with lesions that were ischemia-producing, as assessed by an FFR of less than or equal to 0.8. And it randomized them to those lesions to either PCI versus optimal medical therapy. So in the cath lab, the best way that we can assess ischemia. And you can see the red bar is those patients who were randomized with an FFR of less than or equal to 0.8, medical therapy alone, versus blue is PCI plus medical therapy in the randomized group. And you could see a marked reduction in the need for revascularization. About half of these revascularizations were urgent revascularizations, often produced by either a myocardial infarction or an impending myocardial infarction or unstable angina. On the other hand, the yellow line is those patients with an FFR greater than 0.8, not ischemia producing, treated with just medical therapy alone, and you can see they have an excellent prognosis, and they're very, very stable. Now, this trial was actually stopped early. It had a mean follow-up duration of only 7 months with fewer patients than anticipated because there was such a marked benefit of PCI in keeping patients stable. On the other hand, if you looked at the overall rates of death or myocardial infarction, while there was not a significant difference, there was a trend towards a hazard ratio of 0.61. That is a trend not significant towards a 39% reduction in death or myocardial infarction. With PCI compared to medical therapy, and it becomes particularly insightful when you look at the actual Kaplan-Meier curves. This is death or myocardial infarction, and what you can see is that within the first few days after the procedure, there's an increase, and these are all the peri-procedural MIs from just counting biomarker elevations that we always get, and we know that almost the vast majority of those have no prognostic significance. On the other hand, if you look after that stabilization period, 1 week and beyond, you can actually see that the PCI patients now are very stable in terms of death or myocardial infarction, where both death and spontaneous MIs continue to accrue in the medical therapy arm. And you could see this hazard ratio for a 58% reduction on day 8 or greater. So I think that if this trial was large enough and if it was adequately powered, again, you would have seen in these ischemia-producing lesions a significant reduction in death or MI. Now, the ultimate test of this hypothesis, that is stable PCI patients with significant ischemia, that is 10% or greater of the left ventricle approximately, by quantitative testing, will benefit by repeat revascularization, whether PCI or bypass surgery, is being tested in the ischemia trial. This is an 8,600 patient trial of patients with moderate to severe ischemia by non-invasive testing, again, randomized to either conservative care with optimal medical therapy or an invasive strategy with revascularization either by pre-PCI or bypass surgery. And here the primary endpoint is cardiovascular death or MI. But this trial has recently started. It's a very large, ambitious study, and we're not going to have the answers for about 7 or 8 years. Now let's go to patients with more complex coronary disease, severe double vessel, triple vessel disease, left main disease. You need revascularization. So if we start with just multi-vessel disease, the most robust study we have, well, there are really 2 of them. One is the Syntax trial, and the second is the Freedom trial. Is the Freedom trial. And if you look here, the Berry 2D trial. And if you look here at Syntax trial, took the most complex patients, basically almost all comers, 705 patients with left main disease, either isolated or with single, double, or triple vessel disease, and 1,095 patients with triple vessel disease, in whom revascularization was intended for all 3 vascular territories. And if you look here, what can we say about if we focus now on the multi-vessel disease component? Well, the one thing we can say is that early on there certainly was a benefit in terms of both physical and mental functioning in the PCI patients compared to surgery. And this is now with Taxus stents compared to bypass surgery. And early within 1 month, whether it's mental function, physical function, or overall assessment as measured by the EQ-5D utilities, you can see a significant benefit for PCI. So the overall early, again, 1 month quality adjusted life years are significant. Now by 6 months and then by 12 months after surgery, there's a catch up. And so the patients are feeling just as good. But of course, there's a price to pay within that first month. And that's not a surprise to anybody why PCI tends to be favored, all else being equal. The one other thing we've learned from all of the studies of multi-vessel disease intervention is that there's a higher stroke rate with surgery compared to PCI. And this is a recently published meta-analysis here. You can see in this over 6,000 randomized patients, a 2.6-fold higher rate of stroke within 30 days with surgery compared to PCI. But there's a lot of endpoints other than just stroke that do matter. So if we look now at the triple vessel disease subgroup from Syntax, and we look at the final 5-year data, and we look at the primary endpoint, which was the quadruple endpoint of death, MI, stroke, or repeat revascularization, you could see in these very complex patients, it was markedly higher with Taxus stents than it was with bypass surgery at 5 years. And you could see the curves really separate out at 1 year, and they continue to separate out over time. If we break it down into the components, we could see that mortality was higher with PCI, MI was higher with PCI. By 5 years, there was no difference in stroke, and revascularization was higher. And that contributed to, in triple vessel disease revascularization patients, worse outcomes with Taxus stents compared to surgery. And part of the reason, and I'm going to come back to this, is that with this first generation drug-eluting stent, there was a very high rate of stent thrombosis. So out of 5 years, we had a 5.8% rate of symptomatic stent thrombosis, so about 1.2% per year, contributing to the high rates of death and myocardial infarction. Now, all triple vessel disease is not created equal, and that's where the Syntax score has become a very, very useful tool. The Syntax score is basically an anatomic score, adding up the complexity of all the stenoses that are 50% or greater, looking at how complex a procedure it would become for PCI. So you could have a patient like this with triple vessel disease that has 4 discrete lesions, and the Syntax score is relatively low, it adds up to 21. Or you could have a patient like this with totally occluded circumflex, totally occluded right coronary arteries, and high-grade stenoses of the left main and the LAD, where the Syntax score is very high. at 52. So overall, you can look at this anatomic complexity for PCI, because for bypass surgery it doesn't really matter for the most part how complex it is, but for PCI it really matters. And if you look at the lower syntax score tertile patients, now you see, you got to be a little careful because this is a subgroup of the study, but in 350 randomized patients, you don't see a statistically significant difference overall in the quadruple endpoint out to 5 years. You could see mortality, not that different. Stroke tended to be a little bit less with PCI. MIs tend to be a little bit more with PCI than surgery. And revascularization a little bit higher with PCI, but at least not terrible, and you might consider that worth the trade-off, especially, as I'll talk about later, this was first-generation drug-eluting stents. On the other hand, when you get to the intermediate syntax tertiles of 23 to 32, you see very marked differences favoring CABG compared to Taxus stents in almost every category. And when you look at the high scores, you see the same, even more so. So for triple vessel disease and moderate and high scores, at least with bypass surgery compared to Taxus stents, a first-generation drug-eluting stent, it's hard to argue that bypass surgery should not be favored. Now we now have the FREEDOM trial, which was 1,900 patients with diabetes and multivessel disease randomized once again to first-generation drug-eluting stents, in this case either Cypher or Taxus versus bypass surgery. And the primary endpoint was death, stroke, or MI. And interestingly, the results looked very similar to the triple vessel disease group of the syntax trial, which were both diabetics and non-diabetics. In this trial, interestingly, up to 2 years, there really wasn't much of a difference between PCI and DCS versus bypass surgery. Very similar rates. But then as you followed the patients over time, you could see bypass surgery seemed to be favored. And if you looked at all-cause mortality here out to 5 years, again, no difference out to 1 year, but then over time, bypass surgery is favored. Same with myocardial infarction. Now, stroke was different. Stroke was less with PCI compared to bypass surgery in diabetic patients, significantly less, both early on, and it continued to be less over 5 years, so more than a 50% reduction in stroke with PCI over surgery. And that is important because for some patients, stroke and death are almost equivalent types of adverse outcomes. And I think very, very interestingly, when you look at the results of FREEDOM, according to the syntax score, you see almost identically, at least in my interpretation, what you saw with the triple vessel disease subgroup of syntax, according to the syntax score. And that is not a whole lot of difference in those patients with a low syntax score with first generation DES compared to bypass surgery, but now all diabetics. Whereas in the intermediate or the high syntax scores, there seems to be benefits favoring surgery. Now let's go quickly to left main disease, because the left main disease outcomes tend to be quite different. And I guess this shouldn't be surprising because left main disease is actually a short lesion in a very large vessel. And we know that drug-eluting stents do quite good and in that kind of an anatomic setting. And when you look at the overall 705 randomized patients with left main disease and syntax out to 5 years, there was no statistically significant difference in that quadruple composite cumulative event rate. So this is very, very different than the way the triple vessel disease group of patients looked. And you could see there was no difference in death, no significant difference in myocardial infarction. In fact, if you go back to death, if anything, the point estimate favored Taxus stents compared to surgery, not even a trend towards more mortality. Stroke actually was significantly reduced in the left main patients undergoing PCI compared to surgery, and stroke is always higher in left main patients undergoing surgery compared to non-left main patients. Revascularization still significantly more with Taxus stents compared to bypass surgery, and therefore you can see the non-significantly difference in the quadruple endpoint of MACCE, although slightly favoring surgery. Now, if you break the left main patients down by syntax score, you could see here almost identical outcomes out to 5 years with Taxus stents and bypass surgery in patients with unprotected left main disease as a class, as long as the syntax score is low. In fact, if anything, again, the point estimate favored PCI for mortality and for stroke, favored bypass surgery a little bit for myocardial infarction, and revascularization actually pretty identical for these low syntax score patients with left main disease. And for the intermediate score patients, syntax score patients with left main disease, again, almost identical outcomes, even with first-generation Taxus stents. And again, here mortality statistically was even less with PCI than bypass surgery. Again, although take all these components with a grain of salt because the numbers and the event rates are getting small. But again, stroke tended to be less, MI tended to be a little bit more, and revascularization not so different. When we get to the left main patients, though, with high syntax scores, now you once again see that bypass surgery is clearly favorable. So triple vessel disease with diabetes, without diabetes, and left main disease with high syntax score, clearly surgery quite favored. When you get to the intermediate syntax scores, it really depends on whether or not it's pure left main disease or just multivessel disease. And when you get to, when you talk about the low syntax scores, there PCI, even with first-generation drug-eluting stents, seems to be a good alternative. Now, this whole question about left main disease is going to be definitively answered by an ongoing study called the Excel trial, because again, all the data I'm showing you so far really is subsets of subgroups, and you've got to use a lot of this as hypothesis-generating data. But Excel with 3,600 patients is really powered to show whether or not a current state-of-the-art drug-eluting stent, that is the everolimus-eluting Xience Prime stent, is non-inferior or superior to bypass surgery in 2,600 patients with a syntax score of lower intermediate, that is less than or equal to 32. And we've now randomized over 1,000 patients in this trial, so we're well on our way to getting this answer. Now, the data's fine, but how is this actually performing in the real world? And in this case, we might want to consider the appropriateness use criteria. This, as you know, goes beyond the guidelines by looking for the indications of revascularization based on practical scenarios, such as clinical presentation, severity of angina, extent of ischemia, extent of medical therapy, and anatomic disease. And a 17-member technical panel has graded the appropriateness for both PCI and CABG in 180 different clinical scenarios. And you've all seen these types of plots about when you look at, for example, on the right, patients with Canadian cardiovascular class 1 or 2 angina, according to what their stress test shows and what their coronary anatomy shows, whether or not revascularization is considered appropriate in A, uncertain in yellow, or inappropriate in red, according to this 17-member panel. But how does this perform in the real world? Well, a very interesting study was recently published from Ontario, looking at 1,628 patients with stable coronary disease in whom cath was performed. And according to the AUC criteria, 61% of these patients would have been appropriate for revasc, 20% uncertain, and 19% inappropriate. And actually, revascularization was performed in 61% of the patients, but not necessarily in each of those categories 100% of the time. So it was performed in 68% of the appropriate patients, 18% of the uncertain patients, and 14% of the inappropriate patients. And if you look at the 3-year rates of death or acute coronary syndromes, actually you could see a statistically significant reduction if revascularization was done in the appropriate patients. You could also see a strong trend for a 43% reduction, even if anything a stronger reduction, in those in whom revascularization was uncertain. And it wasn't until you got to the inappropriate group where you saw a trend towards the opposite, that is, against revascularization, although the adjusted hazard ratio by multivariable analysis was basically 1. And if you just looked at death versus ACS, interestingly, all 3 groups tended to have lower mortality rates with PCI compared to medical therapy, and it was actually only more acute coronary syndromes in the unappropriate patients that drove that hazard ratio of 1. So I think in the real world, PCI and revascularization, I should say, not just PCI, but revascularization may be performing better than in these clinical trials. Now, how can we make PCI better? And there have been major improvements since the trials that I've shown you. And the first way is with, again, getting back to this ischemia hypothesis and only revascularizing ischemia-producing lesions. And that's what was tested in the FAME trial, and an angiographic guided strategy compared to an ischemia-guided strategy required more stents, was more expensive, and actually had worse clinical outcomes. So it was better to only stent those in whom FFR said these lesions are ischemia-producing. And the problem is you can't tell from looking at the angiogram unless you get to about a 90% or greater stenosis which lesions are really going to be ischemia producing. So you need either non-invasive or invasive testing like FFR to be able to tell and select those lesions. Now, we've recently looked at a large study called the Verdict First study in 544 lesions looking at QCA, and the flip also holds that we know that angiography can actually underestimate lesion severity, and when you get to even 60% or less stenoses, you can have a significant number that are still ischemia producing, even if the angiogram looks very benign. So you really need ischemia evaluation if you're going to believe the results of both FAME-1 and FAME-2 showing that you get best results by treating ischemia-producing lesions. And it's really hard to tell by the angiogram. So you look at this first patient with a mild proximal LAD lesion, the FFR is 0.71. A mild mid-right coronary lesion, the FFR is 0.91. You can't predict. You look at patient 2 with a mild to moderate LAD lesion, mid-LAD, the FFR is very bad at 0.57, and a more severe looking long right coronary stenosis, the FFR is 0.84, and 0.8 being the cutoff for treating. So you really can't tell from the angiogram. We've actually seen the implications of this by quantitating this, and we've come up with a score which has been published called the residual syntax score. So you measure all the lesions at baseline according to the syntax score, and then you look at what was actually treated. So the original syntax score was 14, but they didn't treat these 2 lesions, so the residual syntax score is 6. That is, they treated a delta syntax of 8. So what's the implications of incomplete revascularization? Well, first of all, it turns out that incomplete revascularization is common. And we looked at a very large database called the Acuity trial in 2,600 patients. We did QCA of every lesion in the coronary tree. And complete revascularization, that is a residual syntax score of 0, was present in only 40% of patients. And as the residual syntax score climbed, as you can see from this paper published in JACC earlier this year, the MACE rates climbed over the course of follow-up out to 1 year. The higher the residual syntax score, that is the worse the incomplete revascularization, the higher the MACE rate. And for every extra point of incomplete revascularization, mortality increases, cardiac death increases, MI increases, and unplanned revascularization for ischemia increases. And this is one of the reasons why PCI doesn't often do well at high syntax scores, and that is because the likelihood of getting a low or 0 residual syntax score, of course, goes down as the baseline syntax score goes up, even with stage procedures. When you've got a lot of disease at baseline, we don't do a very good job in getting complete revascularization with PCI, and that's why you've got a lot of late events. Now, it's also very important to realize that almost all the data that I've shown you so far from the randomized trials was with first-generation drug-eluting stents, that is, paclitaxel-eluting and sirolimus-eluting Taxus and Cypher stents. And we know that while these stents were a godsend for reducing restenosis, they also lead to a large percentage of uncovered stent struts. There's polymer hypersensitivity reactions. You can get occasionally a necrotic change. You get positive vessel remodeling with incomplete apposition and abnormal vasomotion distal to the stents, and therefore you can have late stent thrombosis, which was a real concern with these devices, and sometimes even late catch-up. And we were the ones who I think showed this most completely in the Taxus trials, and you could see while the reduction with Taxus compared to bare metal stent was profound and was maintained throughout 5 years without any late catch-up, you could see there was a late catch-up in terms of stent thrombosis. Stent thrombosis was similar to bare metal stents within the first year, but from 1 to 5 years, more stent thrombosis with Taxus compared to bare metal stents, and same with myocardial infarction. No difference up to 1 year, but then increased MI rates out to 5 years. Well, we now have second-generation drug-eluting stents. Well, here's one that we call generation 1.5, which was the Endeavor zotarolimus-eluting stent from a phosphorylcholine durable polymer. It perhaps has some safety benefits. We don't know for sure, but it wasn't a strong enough drug-eluting stent. The late loss was only 0.6 millimeters, a little bit better than bare metal stent, but not potent enough. But we now have everolimus-eluting drug-eluting stents, which again have a fluoropolymer, which turns out to be very thrombo and platelet resistant on a very thin strut cobalt chromium or platinum chromium stent designs eluting everolimus. We have the zotorolimus-eluting Resolute stent from the BioLinks polymer, which is much more potent than the Endeavor stent. And we have now bioabsorbable polymers eluting another limus analog, BioLimus A9, from the S stent in the BioMatrix stent. And if we look at, for example, the everolimus-eluting stent, second generation, compared to the first generation Taxus stent, we see marked reductions in MACE. A 36% reduction in MACE from these large 6,800 patient randomized trials. And it's both because of better efficacy, reduced ischemic TLR, and better safety, less stent thrombosis. And this has been translated out to benefits in the real world. If you look at very large registries, 12,000 patients, much lower stent thrombosis rates, both early and late, with everolimus-eluting stents compared to first generation DES. The zotorolimus-eluting Resolute stent also has similar outcomes to the everolimus-eluting Xience and Promus stents. Very good overall patient-related outcomes, although stent thrombosis rates may be a touch higher. Nonetheless, there still are ongoing events, about 1 to 2% events per year on a target lesion basis from 1 to 3 years, and we've even seen out to 5 years in SPIRIT 3. So we can get better, even as good as these drug-eluting stents have gotten. And part of this is because of the phenomenon called neoatherosclerosis, the transformation of garden variety neointimal hyperplasia to a necrotic core, which can then rupture and cause an acute coronary syndrome. This probably causes a lot of the late restenosis and late stent thrombosis. This can occur with bare metal stents as well as all drug-eluting stents, although it occurs faster with DES than BMS. And we've seen, again, from pathologic studies, this is becoming recognized as an increasingly frequent cause of late stent thrombosis. So there's 3 approaches you're going to see in the future: metallic drug-eluting stents with bioabsorbable polymers, polymer-free metallic DES, and bioabsorbable vascular scaffolds that may overcome some of these late problems. I've already alluded to the BioLimus A9 stent, which has a abluminal bioabsorbable polymer, and we've already seen now in the LEADERS trial, 1,700 randomized patients, similar 1-year outcomes, but better outcomes from 1 to 4 and now 5 years with less stent thrombosis. The Synergy stent is now undergoing large-scale testing, and this uses a very small amount of an abluminal bioabsorbable PLGA polymer eluting everolimus now on an enhanced platinum chromium stent design. There are polymer-free stents, which have had favorable early pilot experiences where you use micro-etching techniques to hold on to the drug and elute it in a controlled fashion. Or a drug-filled stent, which has holes that will elute the drug in a controlled fashion over time with no polymer, so you have no polymer hypersensitivity reactions. And then finally, and perhaps most excitingly, you have the concept of truly bioresorbable vascular scaffolds. They're not even stents anymore. The concept being that once the scaffold has done its job in supporting the vessel and eluting the drug over the 1-year period that's necessary, it totally dissolves and is absorbed by the body's processes over time, and therefore you would expect to have much less late vessel reactions and the restoration of normal vasomotor responses, which we've seen in the absorbed program with the BVS device. So this has been a whirlwind tour of the current and future directions in stenting. PCI clearly reduces death and MI in patients with acute coronary syndromes. Randomized trials with bare metal stents and stable coronary disease have demonstrated that PCI is more effective than medical therapy in relieving angina and improving quality of life, but not in reducing death or myocardial infarction. However, an ischemia-guided revascularization strategy with current drug-eluting stents may further improve outcomes in stable CAD, avoiding unnecessary stenting and enhancing freedom from death and myocardial infarction. And I think that's how most people are trying to practice now state-of-the-art stenting in these patients. In multivessel disease patients with or without diabetes, PCI with first-generation drug-eluting stents results in comparable outcomes to CABG in patients with a low syntax score, but not with high or intermediate syntax scores, in whom CABG is preferable. But PCI does result in better early quality of life and less stroke in all patients, and the long-term PCI results may be improved with an ischemia-guided stent and best-in-class DES strategy, at least to bring up the intermediate syntax score patients. In left main disease, PCI is currently indicated with a class 2A level of evidence in patients at low risk for PCI and high risk for CABG, so it shouldn't yet be mainstream. Bypass surgery is still standard of care for left main disease, but the ongoing Excel and Noble trials may advance these indications to class 1 within a few years. And finally, by utilizing small amounts of bioabsorbable polymers, polymer-free systems, or fully bioabsorbable vascular scaffolds, future generation drug-eluting stents will likely further reduce stent thrombosis and improve late outcomes.
Thank you,
Roxanne.
Thank you, Greg. A fantastic talk and really a whirlwind tour around. We're waiting for any questions from our audience, and while that's coming through, let me ask you some questions. Sure. I think you came up with some really solid conclusions. Some may not agree with all of your conclusions, especially in patients with multivessel disease and diabetes. And as you know, the FREEDOM study was just recently presented and published in November of this past year. And I think the gist of the study, the plan of the study, and the results are really pointing a lot of the people in the direction that if you have a patient with diabetes and multivessel disease, you absolutely should offer them bypass surgery first and foremost. Now, in your presentation, you did show us some very interesting data on the different syntax score. You showed us that the P interaction was not positive, so there was no interaction, but yet you still want to kind of, on the low syntax score, you think that the jury is still out. Do you want to expand on that a little bit? Because I think that's an important practice changing issue.
Well, first of all, one of the problems, and I kind of alluded to this, is when we make decisions based on the syntax trial, based on Courage, based on the FREEDOM trial, we say, okay, I've got a patient in front of me, and now I can offer them either bypass surgery or first-generation drug-eluting stents without ischemia guidance, okay? And that's a decision that I could use that data set to make a decision on. But unfortunately, medical therapy advances occur, and we have to incorporate new advances. So no one is going to make that decision anymore. The Cypher stent's not even manufactured, and the Taxus stent's been shown to be significantly inferior compared to best-in-class drug-eluting stents right now. So that's one thing you have to take into account. Number two, whenever you look at the results of a randomized trial, you've got to ask who were the patients that were put in the randomized trial. So you can say that you've included a large group of patients, but 86% of the patients in FREEDOM had triple vessel disease. So there were very few patients with double vessel disease in FREEDOM. So first of all, I would say that FREEDOM pretty much applies to triple vessel disease patients. And then, of course, you are going to have, when you look at it, the average syntax score in FREEDOM was quite high. I can't remember the number, but it was over 20. These were complex patients. These were not simple patients, because we all know there's a bias. When you've got simple patients, no one's even thinking about PCI. So again, when you look at the screening logs, of course, all these trials always have 5% of the patients that are screened in. And the simple patients are going to go to PCI, or maybe even sometimes medical therapy, where it was the really complex patients that people wanted to see. We would mostly treat these patients with bypass surgery, but is PCI a reasonable alternative? So when you take this all into account, I think it's very fair, especially when you look at the, about 700 or 800 patients that did have single vessel disease, while subgroups did have low syntax scores. While subgroups are always inherently underpowered, you've really got to look at those curves and look at the syntax curves, triple vessel disease both, and you really looked, and they say they look pretty similar. Then take into account that these are first-generation drug-eluting stent technologies, et cetera, and you've got to say, what do I do with the patient in front of me today? Do I just, jump in the lake and say, well, it's a diabetic trial, so every patient with diabetes? Randomized trials don't include the universe. They include a very small group of patients, and they test a very specific therapy.
So I think what you're saying is take the patients in front of you into context of everything that you know, and really evaluate the risk and benefit. And I think you're absolutely right, because as we move so fast in the field of cardiology, the trials are behind us, aren't they? And things are getting better. But we do have a question, actually, which I think is good. And the question is, do newer stents have better promise in the management of ischemic heart disease? All of these data you presented to us are in old, we're in a whole different new world now. What do you think? And of course, you're examining some of those. Do you believe that this will absolutely make an important difference?
So when we look right now at the current best-in-class drug-eluting stents that we're using, the #1 stent in use around the world is the fluoropolymer-coated everolimus-eluting stent. Okay, whether Zion's Promus or Promus Element. And that stent's got about a 60 to 65% lower stent thrombosis rate and about a 35 to 40% lower overall MACE rate. It's more effective, it's safer. And the big differences are in the first year and then late in terms of stent thrombosis. You know, now we've got newer drug-eluting stents that we think are going to be very hard to improve upon those one-year outcomes, but we're very hopeful that that ongoing curve that keeps ticking up, even with the best drug-eluting stents right now, is going to flatten out with the newer drug-eluting stents. But we don't have enough data to say if any of them are going to do it yet, even the BVS.
So again, another very good question is that when we're talking about all this new generation DES, and he's saying when intervention is warranted and when you actually do decide to do intervention, do you tend to use BMS versus DES yourself? And if you use BMS, when?
Yeah. Well, you know, right now I use, in my own patients, use DES in over 90% of the patients. The only time I would pretty much use BMS would be a patient who either has a social situation or a financial situation where they're not going to be able to either take or be compliant with clopidogrel for at least 6 months. And those would be the patients that I use BMS in. When you look at the meta-analyses, interestingly, it suggests that everolimus-eluting stents have lower stent thrombosis rates than bare metal stents. And Elazar Edelman's group has actually shown that the polymer itself may be thromboresistant and actually protective from platelet accumulation and thrombosis. So I think the data is very good for best-in-class drug-eluting stents in most scenarios, as long as cost and dual antiplatelet therapy compliance is not an issue.
So it has to do with cost and dual antiplatelet therapy for you. Otherwise, you go for DES.
Almost all patients.
Pretty much almost all cases. So with DES, someone's asking, I'm seeing the term neoatherosclerosis lately. What does this mean? Can you describe it?
So normally when we think of restenosis inside a stent, it's what we call neointimal hyperplasia. And that's smooth muscle cells which then produce an extracellular matrix, which has collagen, fibrin, proteoglycans, and other factors in it. And that's usually a very stable type of lesion. And you usually get a certain amount of it produced, and then usually after about a year or so it stops, and then you freeze a lesion. But over time, over follow-up from 5 years, 10 years in bare metal stents, and over 1, 2, 3 years of drug-eluting stents, you can have a transformation of that material into what looks more like atherosclerosis. It actually becomes metabolically active. You get macrophage deposition, you get cholesterol deposition, you get a necrotic core forming, and you get a lesion that looks much more like the typical lesion that causes a myocardial infarction, a heart attack, what we call a thin-capped fibroatheroma. And when you turn what was a nice stable restenotic lesion into now an unstable fibroatheroma, it can rupture. And if it ruptures, you can get thrombus forming and it can cause a sudden heart attack. And with OCT and with pathologic studies, we're seeing more and more that as you follow patients with drug-eluting stents, a greater and greater percentage of their restenotic lesions are transforming into so-called neoatherosclerosis, which then carries this late risk of acute coronary syndromes.
So what's the timing of that? Has that been sort of further elucidated? Or
well, you know, nobody really knows the frequency of which it occurs yet. Does it occur in 1% of patients, 10%? The frequency with bare metal versus drug-eluting stents, although it seems to occur earlier with drug-eluting stents compared to bare metal stents. And the timing, again, seems to be with drug-eluting stents, you can occasionally see it within the first few years. With bare metal stents, it's pretty uncommon until 5 years or beyond.
No, because one is thinking, well, do I have to take dual antiplatelet therapies now for forever, regardless of what you're showing us with some of the newer fluoropolymers or no polymer-free? I mean, is that something that concerns you, neorevascularization?
Well, as you know, we don't, again, if you have neorevascularization and it turns into a lesion which could cause a heart attack, we don't even have any evidence that taking lifelong dual antiplatelet therapy prevents heart attacks in patients with those lesions, you know, in their native coronary arteries. And so far, the randomized trials that have looked at this have actually not shown that anywhere beyond 1 year of dual antiplatelet therapy is beneficial, and perhaps not even beyond 6 months. So in this regard, we're waiting for the long DAPT trial, which is a big 20,000 patient randomized trial looking at 1 year versus 2.5 years of dual antiplatelet therapy, and that's going to give us some insights into whether or not you should be on perhaps lifelong therapy after a stent.
Well, we're hoping that you don't. We want to. Shorter is better, I think. And the other question that I had for you actually is that I'm seeing this progress of going from next generation bioabsorbable, and yet we're seeing these great event rates decreasing with a lot of the stents coming now, and we're seeing also large trials with just 1 month of dual antiplatelet therapy in the global leader study, for example. So, what are we going too far? I mean, when is this going to end? Are we going to be happy with what we've got? Do you really believe that bioabsorbable scaffolds will be the future of stenting?
Well, I'm optimistic. I really am, and that's because when you look at even the best-in-class, stents with durable polymers, you're putting a permanent metallic cage, okay, in the vessel, and that vessel cannot contract normally, and we know that normal vasomotion releases nitric oxide and is very important for normal endothelial health, even downstream from the vessel. And when you've got that cage there, and especially when you've got a permanent polymer, you can just get late adverse reactions. Almost nothing good can come of having the cage there. And therefore, when you look again at all these studies, you see 1 or 2% target lesion-related events per year. And I'm hopeful that everything we've seen from bioabsorbable vascular scaffolds will be able to improve the late event-free survival. Not within 1 year, but within 3 years, within 5 years. But it's going to take us probably about another 5 years and another 5,000 to 10,000 patients in randomized trials to be able to demonstrate that.
I think it's going to be very exciting to see how it goes, and I'm wondering that once those are available, everyone's going to come in and say, I want one of those that that goes away, right?
There's an inherent emotional appeal to that, but again, these stents are thicker than a standard stent, and while they're longitudinally flexible, they are higher profile, and they don't have the same radial force unless you make them very thick. So I don't think they're going to be for every lesion in every patient.
That's right. So we have a very good question, I think, and it talks about DES restenosis. How do you, in your practice, manage it, and what do you do?
Sure. It can be a very vexing problem, and it really depends. Fortunately, most drug-eluting stent restenosis is focal. It's in one little spot. And if it's at the edge of the stent, it occurs in at least half the time, it's often because there was a lesion at the edge of the stent that you just didn't treat. And you can usually put another short drug-eluting stent there, and that will take care of it. If it's short and focal in the middle of the stent, then we'll usually ultrasound it to try to understand why it happened. We want to see, was there a strut fracture that occurred, or was the stent underexpanded at that location, because that's a common cause of even drug-eluting stent restenosis. And you can't tell this from the angiogram, so you have to do ultrasound. And if that's the case, then we'll usually just expand it further and or put in another short drug-eluting stent, either the same or different stent. When you've got diffuse in-stent restenosis, that suggests, either a polymer hypersensitivity reaction or failure of the drug, and there are genetic mutations where in some patients don't respond to all of these drugs, and in which case, depending on how bad it is, you'll always have to restent it, and we'll usually switch to a stent of a different class. For example, paclitaxel if you used Alimis before, or vice versa. And if you have severe refractory, awful, recurrent in-stent restenosis, yes, there are some things. Sometimes we consider oral rapamycin. Sometimes we'll consider vascular brachytherapy, radiation to that area like we used to do before drug-eluting stents. But sometimes the best thing for that patient is to have surgery to bypass that problem, although that's necessary in less than 1 in 10 patients. And finally, I'll say that outside the United States, drug-eluting balloons, that is just a balloon that will elute a drug, has become very popular and effective to treat coronary in-stent restenosis, even of DES, at least as good, it seems, as putting another drug-eluting stent in.
That's great. Thank you, Greg. We only have 2 minutes, but I do have this great question, so we have to answer it short because we do have to close. A question comes, what do you do in a patient pre-kidney or liver transplant? How do you work a patient up like that, and do you believe that revascularization or an ischemia-guided therapy is extremely important? What do you do with those patients?
So, usually, if I understand your question, so pre-kidney or liver transplant.
Or liver transplant. Yeah, what do you do? Let's just say they have coronary disease. Suppose they have 3-vessel coronary disease or what have you. How do you manage those patients?
I think those patients in particular, it's important to assess and quantitate the amount of ischemia. And the question is, can you safely get the patient through the transplant procedure? And I think if they've got a severe amount of ischemia and very tight lesions, that you will want to revascularize them first. Although there's no big randomized trials or evidence to suggest
And
that.
depending on anatomy, you'd go to CABG versus
Exactly,
stenting and all of that. Well, thank you
exactly.
so much, Greg. It was
My
a really
pleasure.
fantastic review of all of the literature, soup to nuts, in advances in coronary stenting. It was a fabulous experience
Thanks,
to
Roxanne.
put you through some questions. So I'd like to thank, in closing, I'd like to thank Daiichi Sankyo Lilly, Abbott Vascular, Medtronic, and Boston Scientific for their support of this important educational series. Please remember to complete the quiz at the end of the session to secure your CME credits, and stay tuned for Aortic Stenosis, a focus on TAVI, or TAVR, with Drs. Jeffrey Popma, Jeffrey Moses, and Chris Cannon. My name is Dr. Roxana Moran, and thank you for joining us, and please come back again.